Good evening, everyone. At the outset, I would like to thank Yashoda Hospitals for creating such a wonderful platform for all of us, for critical care physicians to have such a wonderful discussions with examiners coming from all over India. Then I would like to give special thanks to Vaishali Madam, Senior Consultant Critical Care, Fortis Hospital, Bombay, for accepting to be the examiner today. And again, to my good old friend Santosh, Senior Consultant Critical Care and Co-Director ECMO Program at Citizens Hospital. And I would like to thank even our students, Vishnu and Kirti, who are DRNB students from AIG Hospital, who have willingly accepted to do the presentation with a short notice. So we can move ahead. Welcome, Vaishali Madam. Welcome, Santosh. So you can start the presentation.
Good evening, everyone. Today's talk is regarding case presentation. So this is the 55 years old male who is occupation by auto driver, a native of Hyderabad. Came with the chief complaints of abdominal distension since 4 months and swelling of the bilateral lower limb since 4 months and yellowish discoloration of the eye, which is from past 7 days, and followed by blood in vomitings since 1 day. So coming into the history of present illness, the abdominal distension is insidious in onset and gradually progressive, followed by diffusion and not associated with any pain or constipation. And coming into the swelling of the lower limbs, which is insidious in onset and gradually progressive. Initially, it was having from the bilateral feet. Later on, it extended to the chin and below the knee joint. And no history of any puffiness of the face or any decreased urine output. And no history of any chest pain or palpitations. And coming into the yellowish discoloration of eyes, he was noticed in last 1 week, not associated with any high colored urine and associated with itching or pale stools. So coming into the vomitings of blood, since 1 day, he had 4 episodes since 1 day, which is a sudden in onset, not associated with any pain abdomen, which is around 50 to 60 ml, bright red color, associated with black tarry stools also, and no history of any bleeding per rectum. And also had altered sensorium, altered mental state since 1 day, no history of any fever or seizures history. Coming into the past history, initially he was admitted with a similar complaints 1 year back and diagnosed as chronic liver disease in the outside hospital with OPD management. And also he had no history of any tuberculosis, diabetes, and hypertension, any bronchial asthma, any heart disease in the past, and no history of any blood transfusions or any tattooing history or any no travel history, and no history of any major surgeries. Coming into the personal history, his occupation by auto driver, mixed diet, and he non-smoker, and he consumes alcohol since almost 20 years, approximately 90 to 180 ml per day, and last alcoholic intake was 1 month back. So coming into the summary, so it's a 55 years old male with alcohol consumption since 20 years. With the past history of jaundice, and he also consumed of taking of with OPD evaluation for abdominal distension, pedal and jaundice, and now presented with melena history also for 1 day, and decreased sensorium since 1 day.
So this finishes your history, right?
Yes, sir.
So based on the history, what are your differentials? Vaishali ma'am, do you want to ask anything specifically in the history?
I just wanted to ask, how would you define what is the cutoff for significant alcohol consumption in male versus female?
In coming to the males, the approximate significant is 60 to 80 grams per day, and females is 40 to 60 grams per day.
Yeah, so you'll have to mention the type of the alcohol here, isn't it? In terms of when you said some 90 ml, what is the type of the alcohol? And probably it will be wise to convert it into grams if it's possible to do so.
Do you have any idea about the same?
He's approximately taking like normal whiskey, sir. So normally for whiskey, small 1 peg 30 ml, it consists of 10 grams. So is approximately consuming 90 to 180 grams means it is coming to significant alcohol history, sir. Almost it is like 4 pegs he is consuming, sir.
So 40, how much do you think he's consuming? 80 grams a day?
90.
90 to 180
92.
grams.
Okay. Yep. Any previous decompensations? You said that he is diagnosed CLD. So when he was diagnosed, what was the precipitating event for the diagnosis? So all you want to know is basically there were any previous decompensations of this, or was he a stable CLD and for the first time he has decompensated?
First time he has been significant decompensation with upper GI bleed.
So what are the defining criteria for decompensation? What criteria define that the patient has decompensated in a chronic liver disease patient?
Triggering events predominantly with any significant infections, upper GI bleed.
No. So infection is not. When do you say a CLD has decompensated?
No, what are the clinical conditions for which you will say that the patient has decompensated?
Presence of any hepatic encephalopathy, upper GI bleed, and refractory ascites.
Ascites, not refractory, ascites. And jaundice.
Jaundice.
So, you told about the last admission 1 year back. So at that time, do you have any baseline endoscopy which was done? Any idea?
Patient need for is need for normal intake of any OPD evaluation only, sir. He is need for admission and evaluation, and he taken history of native medicine, and he taken native medicine, sir, for that.
It's not fully evaluated previously.
So history-wise, what's your diagnosis now?
With significant background of significant alcohol history and already prior history of chronic liver disease, it might be predominantly alcoholic liver disease. One thing, ma'am, with decompensation, like with presentation of upper GI bleed, and
there is more decompensation, isn't it? In your history only, there is so many decompensation. He has a GI bleed. What else does he have?
jaundice.
Yes, jaundice, and also he has encephalopathy also. Can be liver acute on
Chronic liver failure.
No, let's not. That will depend on your readings. Currently, he has ascites, jaundice, GI bleed, and encephalopathy.
Yes.
Right. So all 4 things. So he's a decompensated cirrhosis right now. Yes. Whether it is ACLF or not, that you'll need some lab chemistries to be able to decide whether it's ACLF or not. Now that he has decompensated, what could be the precipitating factor for this decompensation?
GI bleed, precipitating.
But it can be any infection that is triggering decompensation.
Okay. Again, in this particular case, with that history which you have told me, what is the most possible precipitating factor for this decompensation?
Most precipitating is upper GI bleed.
Yes, upper GI bleed. Agreed completely. That's the precipitating. But what could be causing all this? The
alcohol.
Yeah, continuing. So alcoholic hepatitis could be one of the precipitating factors. Of course, infection is possible, but in the background, most probably the continued alcohol intake is what is responsible for this decompensation most. We don't know if he was on any drugs, whether he has stopped them, so that there is no way of knowing that. But continued alcohol intake and alcoholic hepatitis is most probably the precipitating factor for all these decompensations suddenly.
So what is your working diagnosis right now, based on the history?
Decompensated chronic liver disease with ethanol, probably ethanol related.
Plus or minus hepatic encephalopathy. You told the patient is in altered sensorium also. Okay, fair enough. Santosh, you want to ask anything or shall we move forward?
Yeah, a couple of questions from my side. Apart from alcohol, do you think there are any contributory factors in the etiology of chronic liver disease?
We should also rule out any viral causes for chronic liver disease. One thing,
Like?
Viral hepatitis, like hepatitis B, hepatitis C, and patient also had native medicine, but what drug is taken, we also don't know that drugs, any drug induced also we have to rule out. Like and
Is he a diabetic?
He's not a diabetic.
not diabetic.
Okay.
So shall we move? Okay, next.
Yeah.
With these complaints, he came to the ER. On arrival to the ER, his airway was clear. He was breathing in a room air, maintaining a saturation of 95%. He was hemodynamically stable. On further evaluation, he was drowsy. His GCS was E3-VT-M6. He was moderately built and emaciated. Weight was around 160 kg. Height was 170 centimeter. In vitals, he was afebrile, BP of 160. Measured on the right upper arm, supine position. Saturation of 95% on room air with respiration rate of 18 per minute.
Sorry, was he intubated? Why is VT? Did you intubate him on arrival?
He was E3-V4-M6 man.
That's
That was type.
Okay.
On examination, there was icterus, there was pallor, there was bilateral pitting pedal edema up to the knee, and there was no cyanosis, and there was no clubbing. On systemic examination, umbilicus was everted, uniformly distended, no dilated veins, scars, or any pulsatile lesions on the abdomen. On palpation, it is distant. All the inspectory findings were confirmed. Abdomen distended, no tender, no guarding or rigidity, no palpable mass, and liver and spleen were not palpable below the costal margin. Percussion dull note was present in the abdomen. There was shifting dullness and there was no fluid frills. On auscultation, bowel sounds were present. On CNS examination, he was drowsy, but is it arousable, not oriented to type, place, or person. His GCS was E3-V4-M6, moving all four limbs, no focal neurological deficit. There was flapping tremors and deep tendon reflexes were normal. On respiratory system, there was bilateral equal air entry and there are no added sounds. CNS wise, no abnormality was detected. After the initial stabilization, NCCT head was done in the ER from the ER and was shifted to ICU for further management.
So can I interrupt you there? Can you classify further what is this initial stabilization? Can you qualify it with more details? What was done for the initial stabilization?
Initially, since he had a upper GI bleed and pallor was present, he was resuscitated with IV fluids, and then that's the thing that's done.
Anything else which would probably be the right step to take in the ER itself, rather than, because ICU transfer might take time, CT will take time. He has a upper GI bleed in a cirrhotic.
So any proton pump inhibitor or anything was started?
So this is most likely to be a variceal bleed, right?
Yes, it is most probably a variceal bleed with the history of CLD on the background. Yes, ma'am.
So before you send him for a CT brain and then transfer to the ICU, is there something which you would like to give in the ER on presentation?
In this case,
okay, that's fine. That's fine. Now, what are the indications of doing a CT brain in a patient of cirrhosis when most obvious reason probably is hepatic encephalopathy? So at what indications would you say that yes, CT is warranted? Otherwise, you'll be scanning everyone with encephalopathy, isn't it? What indications tell you, or what symptoms and signs suggest to you that a CT is strongly indicated?
If there is any focal neurological deficit, because these patients are at higher risk of intracerebral bleeds, if there is any focal deficit, then CT is strongly indicated.
Yeah. And
alcohol history, chronic alcohol history, any seizures, we have to rule out any.
yeah, so not chronic alcohol, but seizures, yes, that also you would want to do a CT. So this probably, so were you involved? Do you think this CT is very justified over here? Is it?
It was
Not
justified.
It could have been avoided, considering there's a clear-cut GI bleed precipitating an encephalopathy, and you clearly said that he was, I think you said he was oriented, right?
Yes.
He's just slow in response.
Probably
There was no focal deficit also. Okay.
On arrival to the ICU,
So before you do POCUS, there must have been an ABG done in the ER, right? Which is like a basic assessment in the ER.
Yes, ma'am.
Which will give you idea about what is his hemoglobin, whether he's acidotic, what is his lactic acid levels, right?
Next slide.
Next slide is there.
Okay. Okay. So now the ultrasound has taken up so much that POCUS comes before ABG. ABG is the backbone, right? It takes the turnaround time of ABG is so quick. POCUS, I mean, I know we are all working in tertiary care and the USG machine is right there, but let's not change the sequence, right?
Yeah, ma'am.
From my side, one question. When you're doing basically a POCUS on a decompensated CLD with hepatic encephalopathy upper GI bleed, what findings do you expect when you do a POCUS in this patient? What were you trying to evaluate?
Can you go back to the previous slide?
Volume status, one thing we have to evaluate, sir, initial as a part of resuscitation, and we should also confirm the CLD changes are there, echo texture of the liver we can see, and ascites evaluation.
No, I'm specific. You mentioned that IVC is 1.3 centimeters with 50%, more than 50% collapsing, fair LV function.
Yes.
So why did you do that? What were you expecting from the heart? From heart's perspective, why do you think is important in this patient to do a POCUS of the heart?
There can be cirrhosis related cardiomyopathy. So
mixed type of shock also we have to rule out.
Mixed type of shock. Is the patient in shock?
on arrival to the ICU, he was not in shock, sir. He was stable.
Okay. So do you think POCUS of the cardiac critical care echocardiography takes a main stage in during stabilization of this patient?
Yes, sir.
So you have clearly said this is decompensated CLD. The reason why he's going to the ICU is because of the GI bleed and the encephalopathy. Ascites wouldn't have brought him to the ICU, right?
Yes.
Now, when you have a GI bleed and encephalopathy, right, the first things first is, yes, you start resuscitation, which what Dr. Santosh is trying to say is that the POCUS took so much precedence here when the patient is not in shock, and you're saying that the lactate is also absolutely normal, right? I think the next ABG says that the lactate is normal, so he's not in shock, isn't it?
Yes.
Right. But yes, I would say that there is a role of POCUS here, because when you want to give vasoconstrictors, especially a drug like Terlipressin, right, you would want to know if the patient is in fluid overload or if there is any kind of diastolic dysfunction due to cirrhotic cardiomyopathy.
Yes.
So yes, preferably if you have the facility, before giving a powerful vasoconstrictor like Terlipressin, which is the question which I was asking you, that he should have received the first dose in the ER. Once you have a variceal bleed, the first thing to do is, unless contraindicated because of some reasons, you should start vasoconstriction. I'm sure you'll come to that in your next slides. But it would be wise to have a
Attention.
good estimate of the cirrhotic cardiomyopathy before you start very strong vasopressors.
Well, cirrhotic cardiomyopathy is one of the complications we are all aware, but it's not that common. Probably I would like the resident to check into the RARV dilatations, the presence of TR, the presence of portopulmonary hypertension. Probably I'll be concerned more about those parameters rather than cirrhotic cardiomyopathy in a patient without shock.
But the major hindrance, just as a unless the cardiologist writes a 2D echo, none of the medical gastroenterologists allows us to start terlipressin.
Well, it's a POCUS, so intensivists are supposed to be trained in POCUS.
Sure. We'll go ahead.
Yeah.
In the ICU,
Let's move. Yeah.
in the ICU, as shown, the APG revealed a high NN gap metabolic acidosis with respiratory compensation, lactate of 2, base excess of -6, with a hematocrit of 20. All the investigations were straight. After POCUS, Foley's was placed for IO monitoring. Ascites Terlipressin was started, and then medical gastro review was taken.
You said lactate is 2?
Yes, sir.
Yes, sir.
Yeah.
After initial resuscitation, he was started on Terlipressin.
Okay. During resuscitation, what was the fluid of choice in your particular specific patient? And how much fluid did he receive in the ER and ICU, followed by ICU?
Initially, 1 liter in the ERs.
Was it guided? What were you checking by giving fluid? In a patient you suspected to have a cirrhotic cardiomyopathy and all the related complications of CLD. So how did you monitor? Any specific precautions, any specific fluids in particular patient when you suspected decompensated CLD? Am I audible?
Yes, sir.
Yeah, I was just asking you about the type of fluid and amount of fluid you want to give in this patient to optimally fill this patient without causing any problems. Secondary to fluid.
Dr. Santosh is asking you about the 4 Ds.
Select initial fluid of choice.
Dr. Kirti and Dr. Vishnu, so do you have any ideal fluid here? See, with the there is so much of confusion. Lactate is elevated in a liver patient. So should you give ringer lactate or should you give a plasma light? So which is the ideal fluid and what is the dose?
Balanced salt solution would be preferred, sir. We would, in this case, only because the lactates were high, hematocrit was low. For initial resuscitation, till we get was started on guided boluses.
Okay. Considering the pathophysiology of the CLD patient when the patients are low oncotic pressure, so probably we have to be very careful regarding the fluid and the amount of fluid which we give, right? So fluid cardiac output optimization secondary to fluid as well as fluid tolerance. Fluid responsiveness and fluid tolerance are both important for intensivist. We want to increase the oxygen delivery to the tissues. At the same time, we don't want to give any complications secondary to fluid. So this particular patient probably requires a little bit more monitoring in terms of fluid, in terms of the urine output, what is a target of MAP in this patient. This is not a septic shock patient where we target 65 MAP or 75 MAP to prevent AKI. So considering the pathophysiology of the patient, probably the MAP has to be titrated, checking the lactate and the base deficit as well as the urine output. Right? I think balanced salt solution is a good choice. And you said ascitic tap was done.
Diagnostic.
Yeah. Why was it done? What was the indication?
To rule out infectious causes also, sir. To rule out spontaneous bacterial peritonitis.
Did you suspect spontaneous bacterial peritonitis in this patient?
Chances. So for diagnostic tab, we have sent, sir.
It's a diagnostic tab, right?
Yes, sir.
It's a diagnostic tab.
Yes.
Okay. Right.
Why should this patient be at risk of having SBP, Dr. Kirti?
The background of chronic liver disease with ascites, portal hypertension, there might be translocation of bacteria. So there's presence of GI bleed might
This
be
particular patient is at a risk of having SBP. Why?
This patient is predominantly with upper GI bleed only, ma'am.
Yeah. So
Probably.
bleed itself, variceal bleed itself can cause translocation and puts the patient at risk of SBP. And I think he was having melena for a day before he came to you. It was not as if he came immediately.
Yes, ma'am.
So yes, it is a wise idea to rule out an SBP, and I'm sure you will show us the ascitic fluid report also.
So
Go ahead.
Yeah, one question from my side. If we ask you to summarize what are the principal causes of ascites in this patient, what would be the answer?
With the background of a CLD and the portal hypertension is predominantly the cause for ascites, sir. And also we have to rule out other causes like any malignancies, any cirrhosis that might be with pre-existing converted into malignancies also we have to rule out, sir.
Well, I'm just talking about the pathophysiology of chronic liver disease, the pathophysiology process, which actually lead to the accumulation of ascites in the abdomen. Apart from portal hypertension.
Hydrostatic pressure.
Probably like splanchnic vasodilation, sympathetic stimulation, sodium accumulation, ascites. Right?
Yes, sir.
Do you agree? Because when we know the pathophysiology of the ascites, probably we can choose some drugs which exactly address the mechanisms of ascites.
Yes, sir. Diuretics.
No, we'll go on to the treatment next. We're just in the starting stage. We're not into the treatment yet. So, yeah, investigations.
Apart from the normal relevant routine investigations, he had underwent.
What are the routine investigations done? What do you mean routine?
Sir, one thing, complete picture was done. He was having bleeds. We wanted to see hemoglobin. Since he has CLD, we wanted to see the platelet count and also WBC count to see for any sites of infection. And then his coagulation profile, PT, INR, APTT was done. His viral hepatotropic viruses were also sent. Hepatitis B, hepatitis C, hepatitis E, and in ABG was already done in the.
Any other investigations we want to send in this patient, considering the history of the patient?
Urea, renal function test with electrolytes.
Okay.
Liver function.
Okay. Can we move on?
Yeah, proceed, Dr. Kirti. Sorry, did you say that the CT brain showed a
Bleed.
There is a bleed?
No intracranial bleed, ma'am.
But you have written, okay.
It's written as intracranial bleed is there.
That's no, sir.
I thought the case was going to go towards IC bleed management.
Yeah. Okay.
Intracranial pathology.
Can you also, before you go into this, show the the CBC, the LFT, everything?
Yeah. Yes, ma'am.
This is day one, right?
Yes, ma'am.
So your WBC counts on admission is 17,630?
Yeah,
Yes, ma'am. His hemoglobin was 9.
And his creatinine is 5.2?
Yes, ma'am, at the time of admission.
Okay.
So can you interpret this LFT for me now? What does this LFT tell you? Have you written INR anywhere? Dr. Kirti, what was the INR on admission?
1.8.
Okay.
Just in the
Can you interpret this liver function test for me?
With the total bilirubin was 43.8 ma'am, direct more than indirect. And liver enzymes, AST is 300 with ALT 61.
So,
So the
formal
ratio
question of this. What does this tell you? What does this LFT with a WBC count of 17,000 tell you? What's happening here to the liver? AST-ALT ratio, what's it telling you?
it is depicting that it is more predicting towards alcoholic hepatitis, ma'am. Alcoholic ability.
Exactly.
So this high, very high bilirubin of nearly 44, right? With the AST-ALT ratio of 300 by 61, and also a raised WBC count, which of course is multifactorial, but this points towards alcoholic hepatitis, which I was saying in the beginning that the most probable cause here for decompensation is alcoholic hepatitis. Now, can you interpret the sodium of 122? What does it suggest? What is happening here? The sodium has become 122, the creat is 5.2. What does this reflect in terms of the physiology in a cirrhotic patient?
Sodium hyponatremia predominantly might be due to hypervolemic state in the background of CLD, ma'am. So dilutional hyponatremia might be possible in CLD patients. So
So hyponatremia followed by raised creatinine. What is happening to this cirrhosis patient?
intense with ongoing intense vasoconstriction, this splanchnic vasodilation, and causes renin-angiotensin-aldosterone system activation, which causes intense vasoconstriction, ma'am. So it further worsening of kidney injury is going on. So that's why there is elevation of predominant creatinine was 5.2, ma'am.
So no, here there is many reasons for the creatinine because he's come into you to hypovolemic shock, but your explanation was right. With worsening portal hypertension and splanchnic vasodilatation, as you correctly said, the sodium will go down, intravenous vasoconstriction worsens, and the creatinine starts going up, and that's the pathophysiology of an HRS coming in, right? So first the sodium goes down, there is severe ascites, sodium goes down, and then the creatinine goes up. This is a very classic sort of ramp of a worsening portal hypertension leading towards HRS. Currently here, there are the creatinine of 5.2 is multifactorial. Now, when I say multifactorial, can you give me the reasons the creatinine is 5.2 over here?
Apart from this splanchnic vasodilation, one thing is
first and foremost, what is the most likely cause of this creatinine 5.2 over here?
With the background of GI bleed, it can be hypovolemia, which is causing elevated
Urea.
Right. Second, what is the second pathophysiology which may be contributing apart from hypovolemia to this creat of 5.2? We just discussed HRS pathophysiology could be contributing. Can you think, and now this is like if you answer this, you will probably get the maximum brownie points. Can you think of any other, from this slide itself, there is a clue that something more is contributing, maybe contributing to his creat of 5.2.
Biliary acid.
Yes,
biliary
is absolutely 10 brownie points. Excellent. So bile cast nephropathy may also be contributing. Bilirubin is 44, and it is known, especially in ACLF, the bile cast nephropathy contribution is much higher as compared to pure decompensations. Now that you have all these, what do you think? Is this patient purely decompensation or is this ACLF? Does he fit into the definition of ACLF?
He's fitting into the definition of ACLF. One
Why? Why is he fitting into the definition of ACLF? So which organs have failed over here?
Renal, kidney once, ma'am, and hepatic encephalopathy.
1 minute. The encephalopathy is grade 1. Does that become failure in the ACLF score, Cliff-Sofa score?
No.
one thing is
Sorry?
Bilirubin.
Yes, bilirubin is 44. Yes, so the liver wise also.
20.
So 44 bilirubin and the creatinine of 5.2. These two, there are two organ failures. You're saying the BP is stable. You're saying the respiratory is normal PaO2 FiO2. And the encephalopathy is only grade 1. And the INR is 1.8, you said. So the INR wise also, he is not, he's not into organ failure. So yes, creat and the bilirubin have crossed into the 2 organ failure. So if you have 2 organ failure, what grade of ACLF is this?
Grade 2.
ACLF grade 2.
Grade 2.
Right. Now, why at this stage do you want to be classifying and knowing that whether the patient is ACLF grade 2 or 3 or 1? How does it help you?
One thing, it helps in prognosticating the patient.
Excellent. Yeah. So if I say this is grade 3, what is the expected 30-day and 90-day mortality? Not this patient, but say if his INR was also 4 at this point of time and he was ACLF 3, what would be the predicted mortality at 30 days and 90 days, approximately?
80.
Without transplant, I'm talking of, right? When I say mortality means in a natural course with medical management. Yeah, you said something. Someone said something. Either one of two said a number.
85%.
Yeah, absolutely right. Yes, yes. It's a very high mortality at the end of 30 to 90 days once it's ACLF 3. And it's important to form that conclusion once you have all the data, because that tells you what is the course this patient is going to have over the next 7 to 8 days in the ICU, as well as over the next 30 days.
Yeah, one question from my side. Sorry, ma'am, sorry to interrupt. So you labeled as 15,000 neutrophils to 17,000 and increased and sepsis ongoing. So how did you come to this conclusion that there is a sepsis here? Patient's lactate is 2. Patient's BP is normal. Didn't require any fluid resuscitation. He's on any inotropes, right? There is no signs of any obvious history of infection. You wrote it as increased and sepsis is ongoing. So how did you come to the conclusion that there is sepsis?
You have to rule out with other utility.
So can you call just raised WBC with neutrophil predominant as sepsis?
You cannot sell based only on the WBC count.
One. Second, when you find the creatinine of 5.2, there is no blood urine nitrogen here. I would not jump to the conclusion of acute and chronic liver failure at this point of time. Whether it is HRS or not, I'm still not sure. Before going on to that, probably I would have done a complete urine examination or a urine microscopy to check what is it, what is the nature of the urine in terms of protein, casts, the osmolality, and probably the FeNA, the urine osmol, the sodium concentration, the urine spot sodium. Probably this will give me a preliminary idea. Probably the patient is an HRS, or it's simply a case of ATN, probably because of hypertension or GI blood loss. So if this patient was in your ICU, how do you differentiate? Make a preliminary diagnosis whether this patient is an ATN or an HRS?
the cache, when coming to the acute tubular necrosis, there might be muddy brown cache. One thing we have to check it out, sir. And there will be more fractional excretion of the sodium. We have to rule out, sir.
Probably we can talk in numbers for the benefit of the audience. If we can come up with numbers, that would benefit, that would help the audience.
Less than 1%.
In terms of urine osmolality, in terms of fractional excretion of sodium, the nature of the sediment, amount of protein, amount of RBCs.
Urine osmolality, in terms of HRS AKI, there it will be more than 500 milliosmoles, sir. When coming to the ATN, the osmolality will be low, urine osmolality, sir. But from that, the cached
Have you kept a CUE report, Dr. Geethe?
CE report not kept, sir.
No, that's okay. I'm just asking you. Have you kept the CUE report in the coming slides?
Not yet, not yet.
Okay, that's fine.
So we are not sure whether this patient has sepsis or not. We are not sure whether this patient is in ACLF or not, because probably 2-3 criteria are met, remaining are yet to be met. And we don't know whether this patient is in HRS or not
Yes,
at this point of time. Am I correct?
yes, sir.
Okay. Thank you. Let's move on.
Yeah, go ahead. This is the slide. Medical gas. Yeah.
Medical gastro review was done. An upper GI endoscopy was done in the first day, which showed grade 2 esophageal varices with active yeast. EVL was done. Patient also received one blood PRBC in the ICU. He was started on empirical antibiotics after taking blood cultures. Ascitic tap was also done, which was sent for analysis. He was started on anti-HE measures. As I told you, octreotide infusion was also started when he came to the ICU. Patient had persistent oliguria despite adequate resuscitation. So he was given 20% albumin and was maintained high mean arterial pressure with noradrenaline.
Yeah, so we'll stop here. Couple of questions on the previous slide. So the patient, what was the patient's hemoglobin?
Or something.
It was 9.
9. So do you think the giving 1 unit of PRBC with a HB of 9 in a decompensated CLD is justified?
But transfusion trigger will usually be more than 7
7.
in case of any.
How much?
7.
7, sir.
So why did you transfuse PRBC here?
Outside report it is shown. Outside report, one report it showed 7 grams per DL.
No, sir. We'll only believe what we have now. We'll not talk about outside reports because the patient is admitted in your ICU now.
Yes, sir.
So was it a good decision to give PRBC?
No, sir.
No. And you stated that you want to start him on empirical antibiotics after culture and ascitic tap. What empirical antibiotic is your choice?
In this case, he was on.
Sorry?
Sir, this he was coming with upper GI bleed, so chances of him getting infection is high. So we'll start him on ceftriaxone 1 gram 24 hours. Initial antibiotic of choice in this case.
Okay. What would be your dose of octreotide?
50 mics per hour.
50 to 100 microgram bolus followed by 50 micrograms per hour.
And you said patient had oliguria despite adequate resuscitation. So how much fluid did he receive put together?
Around 1 liter.
1 liter. 1 liter of fluid.
Okay. Right. And patient had a grade 2 esophageal varices with active bleeding, isn't it?
Yes.
Right. So do you think 20% albumin at this point of time is apt?
Sir, 20% of
What is the rationale for 20% albumin? Is this indicated at this particular point, or what are the indications for albumin in the ICU?
HRS AKI. When coming to the HRS AKI part, it was initiated. So
We haven't had any definite evidence about HRS, right?
yes, sir.
And how much of ascitic fluid was tapped?
Only diagnostic tap initially we have sent, sir.
So we haven't tapped.
Tap.
It wasn't an LVP.
LVP. No.
This is still isn't a case of HRS, right?
Yes.
Patient is not in hypotension. So
Yes.
why did we start albumin?
No, Kirti, the question is there any justification for albumin in hypotension?
Hypotension, no, sir. Only indications for 20% albumin in ICU is one is spontaneous bacterial peritonitis, one is HRS AKI, and one more thing is large volume paracentesis. If you think that are the only definitive indications to start albumin.
Right. I think.
Yeah. If you don't have answers, we'll move on.
Okay.
Few investigations, the viral markers were negative. The tropical fever panel was negative.
What exactly do you mean by tropical fever panel?
What all have you sent in the tropical fever panel?
This case we sent dengue, malaria, and scrub typhus.
Do you want to consider lepto as probably one of the cause?
Yes.
One cause hepatorenal syndrome. Okay.
On evaluation of ascitic fluid, the total counts was 100. It was predominantly lymphocytes. It was a transudative fluid, that is high sag, low protein ascites. The complete urine examination, 1 to 2%, no bile cast nephropathy, no cast on microscopy. And there was on upper abdomen, there was hepatomegaly, feature suggestive of cirrhosis, and ascites. There was no other lesions.
I think, did we see this? Yeah. Did we get a ultrasound abdomen to image the kidneys? Because we are assuming very strongly that it is a case of HRS.
There were on USG, there was no
structural abnormalities
found on ultrasound.
Did you kind of inquire about the history of the patient? Is there a history of NSAIDs, any history of transfusions? You just said the patient had history of indigenous medicine or native medicine ingestion. Can that be a cause of AKI?
Yes, sir. Yes, it can cause renal injuries, sir.
Yeah, because we have started the treatment for HRS with terlipressin, albumin.
Yes.
I don't see any definite evidence of HRS. Tell the slide.
So, Dr. Kirti, the way to answer that is, what are the defining criteria for HRS AKI by the International Club of Ascites given? Does he fit into all the criteria? And then you have the answer whether the patient has HRS or not. You know the 5 points that is required for HRS AKI. So first of all, have the definitions changed now for HRS? Initially, they used to be classified as HRS type 1 and 2. Now, what are they called as? Has the ICAI changed the definitions?
HRS acute kidney injury and HRS AK and CKD, but type 2 was changed.
So there is HRS AKI, there is HRS AKD, and then there is
CKD.
AKD. Right?
AKD.
What
AKD.
are defining criteria for HRS AKI?
One thing is there should be a raise in creatinine of more than 0.3 in 48 hours or more than 50%
Absolutely.
baseline.
Yeah.
There should be presence of liver disease with ascites.
Yeah.
And should not be any history of any nephrotoxic medications in the past.
Yeah. Yes.
There should not be any structural
Yeah. No proteinuria.
structural damage.
Proteinuria. Yes. Now, does he fit into the definition? Does he fit into all these criteria given by the ICAI?
The old medication that
No
the medication that he has taken, we are not sure whether there are any nephrotoxic medication.
So let's assume that we don't know that. Does he fit into the criteria of HRS AKI given by the International Club of Ascites?
Yes,
he
ma'am.
fits into the criteria of HRS AKI.
He does. That's right. He does fit into the definition of HRS AKI. In fact, earlier in HRS type 1, it used to be said that infection should be ruled out, but that has been taken away now. And in SBP or even upper GI bleed can be the biggest precipitating factor for the most commonest precipitating factor for an HRS AKI. Continue.
The patient remained olivuric and worsening AKI. He was started on Terlipressin after adequate resuscitation.
What dose, Dr. Vishnu? What dose and how was it given? Very important in the management of HRS AKI. What dose do you give? How do you give?
Management of HRS AKI, first is initial resuscitation is more important.
No, my question
Terlipressin.
Terlipressin, what dose and how?
Start with 2 mg in the first 24 hours.
And how do you give it?
IV infusion over 24 hours.
Yeah. Why not bolus doses? Why can you not give 1 mg 12 hourly? Is there any evidence that the continuous infusion is better than intermittent bolus? There is. Please read up the evidence.
Okay.
The side effects are less. Now, coming to that, what are the side effects of Terlipressin? Once you have started this patient on Terlipressin, what will you ask the nurse to monitor?
Bradycardia, we have to look
Okay.
one thing, and the cardiac.
What are the commonest side effect of Terlipressin?
Vascular complications, we have to any discoloration of the.
Yeah, absolutely. Ecchymosis, right? Skin discoloration and diarrhea.
Diarrhea, yeah.
Diarrhea is one of the limiting factors, and sometimes the diarrhea can be so much that you have to stop Terlipressin and use noradrenaline instead of Terlipressin to keep. So now once you have started 2 milligram of Terlipressin, what is the purpose? What is the aim? What targets are you going to give to the nurse, or what do you want to achieve in the next 24 hours once you've started Terlipressin? What's the single most important factor which you want to alter by giving Terlipressin? Which number is important here after Terlipressin? Huh? Sorry? So the MAP has to rise by more than 10 mmHg, and it is advisable to keep the MAP anywhere between 72 to 82. There is a REMAP study, and currently the higher the MAP, that doesn't mean more than 8, but 75 to 82 is a good target to achieve. And This is what happens, that you start and you don't reach that map, and then you will realize that the urine output hasn't improved. And the creatinine, how much should the creatinine come down by once you have given terlipressin for 48 hours, which tells you, yes, this is adequate response? What is that percentage by which the creatinine should go down? It should be by 20%, right? In the end of 48 hours, the creatinine should have gone down by 20-25%. That tells you that the patient is responding. Otherwise, you step up the dose of terlipressin, right? Go from 2 milligrams to 3 milligrams. What is the maximum dose of terlipressin in the Western literature? I'm underlining Western literature. To what dose can you go up to? You must know pharmacology of terlipressin very well, since you are presenting a case like this, 6 milligrams, right? That's Western literature, but in India, we usually don't go beyond 4 milligrams. Our patients don't tolerate it. You'll start having peripheral skin issues if you go beyond 4 milligrams. But yes, the literature says 6 milligrams. Now, how many, if you start terlipressin to 100 such HRS AKI patients, by the world literature, so by all the trials so far, how many of them actually respond? Only 50%, right? The rest 50% don't respond. Some have partial response, some have no response. Now, when I say full response, that means how much should the creatinine be? Please read up. I'm kind of read up HRS AKI, right? The creatinine should be within 0.3 of the baseline. If you know the baseline, and the baseline is usually within the last 7 days, or the one known in the last 3 months. So if it comes within 0.3 of that, then there is a complete response. Anything above that, but it is still less, that's a partial response, and no decrease of more than 20% means there is no response. Why we need to be aware of this is because the non-responders have a very bad prognosis. Okay. Now, once a CLD patient develops an AKI, right?
Okay.
What's the prognosis of these patients once they have developed HRS AKI? What's the overall prognosis? Okay, go ahead.
Now, this patient is already on NORAD, if I'm not wrong, Dr. Kirti. Is he on NORAD?
Yes, sir.
So what is the benefit of starting terlipressin again on a patient who is already on NORAD?
Yes, we can.
Is there any additional benefit of starting terlipressin over NORAD? Or like
vasodilation? Yes, sir.
is there any conclusive evidence that terlipressin is better in for patients in ICU compared to NORAD is better than terlipressin, or terlipressin is better than NORAD?
When we compared noradrenaline with terlipressin, it did not show any mortality. Did not show any mortality.
So there is no. Do you think there is no benefit of starting terlipressin over NORAD, who's a patient is already on NORAD?
Yes.
I think we have some robust evidence now in patients in ICU. NORAD compared with terlipressin is almost as good as each other. There is no superiority of terlipressin or NORAD over terlipressin. As I can confidently say that NORAD is as good as terlipressin in patients in ICU. Right. Let's move on. Right. So, is that the end of the slides?
Yes, sir.
Right. So, my question, couple of questions. Does the patient have infection?
Blood cultures were still awaited, sir, according to the evidences that we have. There was no commonest infection, though those are not there. Commonly UTI or spontaneous bacterial peritonitis, that was not ruled out. Chest X-ray, there are no infiltrates. Blood cultures were still awaited. We don't know the source, but it looks like there is a infective source.
Is this patient is an acute decompensation of CLD or it's a acute and chronic liver failure? If so, justify your findings.
It fits into the acute and chronic liver failure, sir.
Just enumerate the list, the diagnostic criteria for acute and chronic liver failure. SOFA CLIF.
With acute hepatic insult in the patient with pre-existing chronic liver disease, with worsening jaundice and coagulopathy more
So
than
we'll go by the numbers, sir, because
jaundice more than 5 milligrams per DL and INR more than 1.5. With complicating within 4 weeks by ascites and hepatic encephalopathy is criteria for
hepatic encephalopathy. What should be the grade, Dr. Kirti? What should be the grade of hepatic encephalopathy
3 to 4.
to fit into the SOFA CLIF criteria for ACLF?
3 to 4. 3.
It's two. It's two or more. It's two or more. And other criteria in terms of the platelets, in terms of bilirubin, in terms of creatinine, in terms of MAP.
Lipsura.
CLIF SOFA score, any one of the organ system should be involved, sir.
How many organs are involved in this case?
In this case, kidneys and liver is involved.
Bilirubin.
So do you think it's a grade 2, right?
Grade 2 ACLF.
What could be the approximate mortality in this patient?
85.
That's grade 3.
60% probably.
No, grade 2 is around 30 to 40%. Grade 1 is 10 to 20. Grade 2 is 30 to 40. Grade 3 is 70 to 80. So let's suppose if this patient has acute and chronic liver failure and the patient is already on antibiotics, the patient is still anuric, the patient is clinically worsening in terms of the oliguria, in terms of probably shock worsening. So how do you manage this patient? ACLF.
How did you manage this patient further going forward?
Next, we should.
No, did you list him for a transplant? What happened?
We should develop it.
Ideally, for first thing, he's a candidate for transplant because the mortality is high. So we'll first list him for transplant. One more thing is his bilirubins are high, ammonia was high. Planned for any replacement therapy till he is gets transplant to improve his survival. Either
are there any potential contraindications in this patient for future transplant? Did you check? Or could there be any complications associated with CLD which can be potential limitations for transplant in future?
We still did not evaluate this case for the transplant, sir.
What are the general limitations for transplant in a patient with decompensated CLD, ACLF?
Severe portal hypertension.
So conditions like ongoing sepsis, portopulmonary hypertension, right?
Yes.
These are probably some conditions, they could be a limitations for transplantation in the future.
I think we are already time up. It's already 8. So there are few questions. Okay. Vaishali ma'am, anything you want to just conclude?
No, I think what I would like to tell Dr. Vishnu and Dr. Kirti is maybe this was on a presentation on a very short notice. That's quite possible. But the flow to the presentation is not very sequential, right? Also, we still don't know the conclusion of this case, what happened to his AKI, and what is the plan for him in the next 4 weeks. You could have made some slides, as somebody has already suggested. You could have made some slides about the SOFA score, where he fits in, which he's crossing. I think somebody has already said that if you could have make slides with the scores, that would have been adjunct to explaining yourself better, and also defining the ICAI criteria. But well done, right? You did get the 10 brownie points. Sorry, I have to, because you could point out an important pathophysiological mechanism of AKI and ACLF, and that is bile cast. Now, Dr. Kirti, the definition which you said of ACLF is the APASL definition, and that is what, yes, is recommended we should follow in the Indian continent, especially when the precipitating factor is alcoholic hepatitis. But what Dr. Santosh has been referring to is the CLIF definition, the CLIF so far definition. So the Western EASL definition of ACLF, they are slightly different. The APASL definition of ACLF catches the patient quite early.
Yes.
And then when it is not caught at that stage and the patient progresses, that is when the CLIF SOFA score and the EASL definition of ACLF comes up. But your definition was correct. The only thing you should have qualified is that this is the APASL definition of ACLF. Dr. Manindra, can I exit?
Yeah, sure, ma'am. Sure, ma'am. Thank you, ma'am. Thank you for your time, ma'am. Any closing comments from you, Dr. Santosh?
Yeah, I mean, good job, guys. It was a good presentation, but we can do much better.
Thank you.
Yeah, if there are no questions, probably we can end the session.
I think there are a few questions. I think we can answer them at
Yes,
later
yes.
because of time constraint.
Yes.
Thank you, Vishnu. Thank you, Kirti. Thank you, Santosh. Thank you for your time.
Yes, thank you so much.
Good night, guys. Good night.
Good night.